Good afternoon and welcome to the 68th Annual American Healthcare Convention. Today we're with Fred Benjamin from Lexington Health Network. He's the president of the Skilled Nursing Division. Welcome, Fred.
Good to see you, Chris.
Good to see you as well. Wow, what a year.
You're not kidding.
Lots going on. We have a lot of regulatory and reimbursement, but one of the things that I haven't spoken about today is the RCS, the Resident Classification System. Can you tell me a little bit about what's going on in your organization and how you perceive this will affect?
Sure. Well, rehabilitation obviously is something it's a primary reason that people come to skilled care facilities, and when you change the reimbursement system surrounding rehabilitation, it causes a lot of people to be concerned about what does this mean. So we've been trying to answer that question internally for ourselves, and some of the early thoughts that we've had, first of all, to do some financial modeling and to see what the financial effect would be based on completing the MDS form that we have right now, and looking at RUGs pricing, if you will, compared with the proposed pricing under an RCS system. But that's the least important part for right now. I think the most important part is what is going to change in the way that we provide services to our residents. And to my mind's eye, one of the potentially good things about RCS is that it will take into account a lot of the other kinds of comorbid conditions, and will hopefully better track more medical, surgical kinds of diagnostic elements for us. So we're right now trying to figure out how our programmatic planning will be affected at our facilities, and therefore if we need to develop some new kinds of programs that we don't offer now, and also to try to figure out what the continuing role of therapy and rehabilitation will be inside of our company. But one thing is for sure, though, when we try to see this through the lens of our patients, we need to provide the rehab services that they need and that they expect of us. What has been changing, of course, has been the length of stay, and what we're finding is that the trajectory of people's improvement can be speeded up a little bit, but the changes in going from a couple of years back, 30-day length of stay, to some of our facilities and some of our diagnostic elements of 13, 14 days, and for some of the orthopedic conditions, looking at those and seeing that skilled care is being bypassed in many instances, and what's left, we're still being asked to get people in and out, sometimes in 7 days or less.
Interesting. How many properties do you have?
Lexington has 10 skilled facilities, 2 assisted living facilities, 1 independent living facilities, all larger buildings, all in the Chicago suburban market.
Very good, very good. And that's different when you have multi-facility handling all the change versus having one facility. The pressures are there either way, but do you have any insight or, recommendations on how to handle that with a multi-facility change?
Sure. Well, I don't think that anybody can predict exactly what the response could be, because every market is a little bit different, of course. But one thing that does stick out to me is the presence, particularly in large urban markets, of large hospital systems that are geographically distributed, multiple hospitals. We have a couple of those in the Chicago market. So we have the opportunity at the system level to work with health system partners, which is different than working with individual hospital partners, because they're trying to achieve a little bit broader kind of mission, and they're more focused on population health as opposed to specific clinical diagnostic entities. So we're trying to partner up with the larger systems and find out what clinical programs they need in what specific locations, and how we can figure out ways better to partner with them.
So that's brilliant. And so with regards to, let's just say, clinical programming, have any of your buildings, created a niche for the respiratory therapy, or are you there yet, or are you on your way with that niche?
We've had specialty clinical programs for a long time. Those aren't new. What is different is the willingness of physicians and hospital systems and their post-acute networks to have discussions with us about the handoffs. And as we continue forward with penalties in reimbursement for people being readmitted to the hospital 30, 60, 90 days out, Lexington is well positioned because we have home health and hospice and some of the other services, and hopefully we can tie those up in ways that allow us to design a clinical program that begins before people get to our facility and ends significantly afterwards, so that we can achieve optimal outcomes without people going back to the hospital.
That's amazing. Tell me, the Mark Parkinson keynote, he brought up a slide, talks about, we're the best deal in town,
We are. We're the low-cost provider. We're the low-cost, high-quality provider, without a question.
I'm 100% with you. And you talked about length of stay, and so the national average per the PEP reports is 21.3 days, but I know that I have clients that have orthopedic patients 11.6 days. So having said that, though, if they want, we're looking at readmissions, we're looking at length of stay, also thinking about this the best deal in town. Do you think that as this evolves, the length of stay will be the same, smaller, or maybe get a little bit longer when they start tracking hospital readmissions or ER?
Wow, that's a loaded question.
I know, I'm sorry about that.
I mean, no, but it's the real world that we live in, of course, because the payers want to pay less, and the pressures on the insurance industry and created demographically within the Medicare system and the Medicaid system. Every governmental entity has its own financial pressures, and the insurance companies have their financial pressures as well. And consequently, I think that in the short term, anyways, the length of stay will continue to be pushed down a little bit as we continue forward. If people continue to if life expectancy continues to grow, then the kinds of illnesses that we see and the trajectory of treatment is going to change as well. But it's all under the veil of who can afford to pay for the care.
Exactly. Thank you so much. That was a wonderful answer. Our time is up.
Okay.
Thank you, Fred Benjamin. Wonderful discussion, and we'll see you soon. Thank you so much.
Thank you, Chris. Appreciate it.